the frontline options for a adenocarcinoma patient without a driver mutation that's PD-L1 negative is evolving rapidly. I would have said if we had this conversation 6 months ago or 12 months ago, I would have said chemotherapy with or without bevacizumab. And the chemo backbone that people use are different. Some people use carboplatin, paclitaxel, bevacizumab. I tend to favor carboplatin, pemetrexed bevacizumab based on its better tolerability. But the world is changing in the frontline arena. We now have immunotherapy that can be added to chemotherapy. So we have data coming from Keynote 189 showing carboplatin, pemetrexed, and pembrolizumab may be an approved regimen. And then finally we have the 4-drug regimen from Empower 150. Carboplatin, paclitaxel, bevacizumab, atezolizumab. And I think this is where treatment decisions really have to be individualized. For a never smoking patient with a PD-L1 less than 0%, it would be unlikely for me to use immunotherapy. We'll have data very soon to understand what the benefit is of pembrolizumab in PD-L1 less than 50% when added to chemotherapy. But for a never smoking patient, who I'm trying to elicit a response, I would generally use a regimen of a platinum doublet with bevacizumab. We want to get a response, we want to decrease the tumor burden, we want to lessen symptoms. In a never smoker, I'm just not confident that immunotherapy would do that with a PD-L1 of 0%. And so this is a case where I would consider using the triplet of carboplatin, pemetrexed, and bevacizumab, or if you want to go strictly by the ECOG 4599 data, carboplatin, paclitaxel, bevacizumab. There's lots of rationale to adding bevacizumab for this patient who has a PD-L1 low, who's a never smoker, who's symptomatic. We know that from the ECOG 4599 study, when we added bevacizumab to cytotoxic chemotherapy, it improved response rate, it improved progression-free survival, and it included overall survival. And in a very young, fit patient like this, bevacizumab would be routinely incorporated in my platinum doublet. Bevacizumab is not for all patients, and I don't add it to every patient I see I don't add it to a platinum doublet, but for patients who are young, who are fit, who are never smokers, who lack a driver mutation, and who are PD-L1 low, until I see more data from Keynote 189, we'll have that very soon, I would favor using bevacizumab in combination with carboplatin and pemetrexed. Age and performance status factor in for me when I'm thinking about using bevacizumab or any anti-angiogenic strategy. I generally do use this regimen in younger patients. I think the benefit is there in younger patients. And then performance status, I think, is important. This drug, while well tolerated, can add toxicities. So patients with a performance status of 2, those are patients maybe I wouldn't use 3 drugs, rather I would use 2, just a platinum doublet with carboplatin and pemetrexed. But for patients who are younger, who are fit, this is, I think, the right scenario to consider the use of bevacizumab in combination with platinum doublet.